My name is Sandra Faias and I'm a gastroenterologist at the Portuguese Institute of Oncology in Lisbon, Portugal, and I'm affiliated with the group of systematic reviews of University of Beira Interior in Covilhã, Portugal. On behalf of my co-authors, I am pleased to present our recently published article in GI Endoscopy entitled A Comparative Analysis of Glucose and CEA in the Diagnosis of Pancreatic Mucinous Cysts, a Systematic Review and Meta-Analysis. Asymptomatic pancreatic cysts are increasing diagnoses in clinical practice and are predominantly mucinous premalignant cysts. The differential is important for clinical management with surgery required for high-risk and malignant cysts, surveillance for premalignant, and no follow-up for benign lesions. Endoscopic ultrasound with fine needle aspiration for pancreatic cyst fluid analysis is recommended in possible significant lesions, and CEA is the standard biomarker for diagnosis in mucinous cysts. In a previous publication, including 82 patients, we found that glucose levels in pancreatic cyst fluid using a simple glucometer with low glucose less than 50 to be more accurate than elevated CEA above 192 for mucinous cyst diagnosis. We found more publications with the same results, and glucose has additional advantages of low cost, minimal sample volume, and immediate results. So these reasons lead us to perform this meta-analysis comparing the accuracy of glucose and CEA for mucinous cyst diagnosis. We performed a comprehensive search of the literature and included 131 studies evaluating CEA and 4 studies evaluating glucose. For mucinous cyst diagnosis, the pool sensitivity and specificity of CEA was 67% and 80% respectively, versus 90% and 82% for glucose. So, a significantly higher sensitivity of glucose with identical specificities for both biomarkers. We performed a sensitivity analysis confirming these findings were robust. We analyzed publication bias that was not determinant of these results. This is the first meta-analysis comparing CEA and glucose for mucinous cyst diagnosis. The specificities of both tests are moderate, so these are proper tests to confirm the diagnosis, but due to low sensitivity, only 67% for CEA, is not adequate to exclude a mucinous cyst diagnosis, so is not useful to discontinue surveillance of benign cysts, while glucose, with its higher sensitivity of 90%, is excellent for this purpose due to a lower rate of false negative results. Limitations of our study include modest sample size and small numbers of studies evaluating glucose. Furthermore, all patients were operated, what does not reflect real-life practice in which most cysts do not require surgery. However, we did it because surgical specimen is the gold standard for diagnosis. Even so, with these results, glucose may become the screening test for mucinous cysts, particularly of small cysts with limited volume of pancreatic cyst fluid available. Further studies comparing CEA and glucose are needed to confirm glucose as the first-line biomarker for triage of mucinous cysts, possibly replacing CEA due to its superior accuracy, lower cost, facility, and availability. Of course, studies of cost analysis will be important. Due to higher sensitivity, glucose is better to exclude a non-mucinous cyst from surveillance, and will also allow to reclassify a significant number of indeterminate cysts, those presenting CEA levels between 5 and 192, and leading to discontinuation of surveillance with fewer unnecessary MRCPs and US exams performed. Thank you again to GI Endoscopy for the opportunity to discuss our article. We hope you enjoy reading it. Thank you.